Okay, we're going to kick off with our wonderful panel this morning. First up will be Bruce Christensen. He's the Executive Director at Mountain Valley Developmental Services. He's going to speak about his programs and services, followed by Renee Carroll-Great, who is the Executive Director at Response, which is Pitkin County's domestic violence, sex assault hotline and service provider, followed by Jackie Scramstad, who is, as of about 3 months now, the Regional Director for Mind Springs Health, Eagle, Pitkin, and Garfield County programs. And she's going to speak about her programs and services in the mental health community. And then Jess Hankins is a public health specialist, thank you, in Garfield County. And Jess is the new lead for a newly forming, I believe the first meeting was just several days ago, of a group that's called Care Coordination Network. And she's going to speak about what that group is aiming to accomplish. And again, the theme today is support services for adults. It's not a comprehensive presentation. Not all areas of services for adults we're covering today, but just we did identify a few. And the theme is really about this issue of integrated care, care coordination. We want to hear how services are progressing along those lines. So thank you very much for coming, and we'll kick it off.
Thank
you, Bruce.
Again, my name is Bruce Christensen. I'm Executive Director at Mountain Valley Developmental Services, which I'm very pleased to have been there for 37 years in that position. So, and won't be for that many more, but a few maybe. Our organization is probably a little bit more specialized than a lot of the health and human services entities in that we only serve people with intellectual and developmental disabilities, which is a pretty small segment of the population. Generally, we're looking at somewhere about 0.5% of the total population of an area is in need of support services. That is expanding a bit because our field has changed a lot over the last few years, and I'll touch on some of that in a minute. Just a very, very quick overview. We're statutorily, we're much like the community mental health centers in that the state of Colorado has designated regions, and then within each of those regions there's a provider that's been designated by the state. In our world, it's called a community center board, which has basically nothing to do with much of anything other than when we were formed almost 50 years ago. The intent was to move services for people with intellectual disabilities from state-run institutional settings to community-based organizations like ours. In our case, we serve 4 counties: Eagle, Garfield, Pitkin, and Lake. We have services or facilities in Leadville, Vale, Edwards, Glenwood, Rifle, Silt, Rulison, which is interesting, and then coming back up this way, Carbondale and Aspen. We also, under agreement with one of our counterpart entities, have historically and continue to provide services to folks who live in Marble, which is actually in Gunnison County, but because of, as we all know in this part of the world, geography doesn't necessarily match with political borders, so we've always served Marble as well. We serve children birth to 3. Over 400 children and families each year receive services from us. And just very quickly, one thing, even though we're talking about adults, that we're maybe most proud of is last year only 34% of the kids that we served in our early childhood program went on to need special education services upon entering the public school system. So perhaps the biggest bang for the buck in terms of public services are those early intervention services where mitigation at an early age makes a huge difference. All of those services, we don't have staff that provide them. All of those are community-based. We broker and fund services based on the individual family needs and the resources in the communities. With regard to adults, which is what we're here to talk about, Just yesterday we had our annual audit report. We provided over 35,000 days of residential services last year to adults that live in residential facilities ranging from, we have 8 licensed group homes that we operate, to where over half of our people live independently in their own apartment or their own home with 1 or 2 roommates perhaps, sometimes peer roommates, sometimes just community roommates that share facilities that we own or rent with a person with an intellectual disability. We have 3 day program sites for people who have a very serious disability or are older and are no longer interested in employment. Those are located in Minturn, Glenwood Springs, and Silt. And then another program that we're quite proud of, I should have learned this by now. I spent 8 years of Paul and Glenwood putting the thing in front of my face at city council meetings. Anyway, in employment services, historically, entities like ours provided service for work in things called sheltered workshops. Those are actually no longer even legal in the state of Colorado. The bulk of our employment services are provided through supported employment and community jobs, and one of the things we're especially proud of is for the last 10 years we have consistently either been first or second in the state with the number of people that we serve that are employed in community jobs. Part of that is because of, as we all know, the workforce issues in the communities that we serve tend to get tight, and our people provide a good, stable workforce that is sought out by employers, and we have a lot to offer for that. Changes during the past 10 years have been pretty phenomenal in our field. As I mentioned, congregate settings are going away. Everything is much more individualized for adults, and when we get into talking about case management and collaboration, that's where that becomes really important. We no longer in our field look at any kind of a 1 or 2 or 3 sizes fit all, but instead the services are designed to meet the needs of each individual and are extremely varied. There have been some innovations that have been interesting and good. We now can provide services through family members. We provide funding to family members to allow them to keep their own person in their own home. The amount of funding is significant. We have 2 families that receive over $80,000 annually each to care for a child, an adult child with a very significant disability. And that's allowed a change in the treatment modality where somebody doesn't move out of their home at 21, they can stay in their home. But it also provides security for the family because all of the states have funding problems, and we have a waiting list. So it allows people to obtain funding at age 21, serve their child in home, but then when the parents get older, the child's able to move into some sort of supported living environment that we operate. With regards to, all of our services are funded through Medicaid waivers, or the majority are. Our budget is just under $10 million. We have 160 staff. We're pretty large for a fairly behind-the-scenes entity. All of those services are funded primarily through the Medicaid waivers of the state, with only about 10% of our funding coming from non-governmental sources. With regard to collaboration, because of the fact that the population we serve has very, very high support needs, ranging from total personal care to behavioral supports to lesser supports, but still needing someone to help with budgeting, meal planning, homemaking, and things like that. We have always needed to collaborate with other entities and continue to do that. Our primary partners are, we work with MindSpring. We have a lot of people with coexisting diagnoses, Those tend to be, maybe for both of our entities, maybe the most difficult group to serve because they don't fit the primary needs that the majority of our caseload need. They have very, very significant cross-organizational needs. We have always worked with the medical community. Folks with intellectual and developmental disabilities tend to have greater health care needs maybe than the normal population. There's some issues, for instance, 100% of the people with Down syndrome will get Alzheimer's disease at one point in their life. And you know, it seems like there ought to be a research opportunity there to figure out what the reason for that is. Our folks are living longer than they ever have before, so suddenly we're dealing with a geriatric population that didn't used to exist. The oldest person that we serve right now is 83 years old. The youngest person is probably 1 month old. And so we're needing to learn to adjust our services for folks that are aging. One of the technical problems that it's causing is most of the houses and residential buildings in our region are two-story buildings. It's a more economical way to build a house. And suddenly we're dealing with an aging population that can't deal with stairs, and we're modifying homes. We built a specialized facility in Carbondale a few years ago, and it's a big challenge that we're needing to learn to deal with, and it's probably a challenge that all of the human services are needing to expand, because we find out all the time that, you know, people like me are living longer, and some of us are still physically fit, but we're able to maybe foresee the day that we aren't going to be able to, in my case, ride my bicycle 100 miles at a time. That day may have passed last year in my case, I'm not sure. But anyway, we also do a lot of work with the public school systems, because both on the transition from our early intervention program to the public schools, but also with adults. And that's been a challenge for us because we work with 6 school districts. Each of those districts has different capabilities and resources. And also, unfortunately, it seems like the people in the special ed programs in the school districts move a lot. So we just develop a relationship with one set of people in one district, and all of a sudden they're gone, and we have to find new people. And one of our major goals for this year is to do more outreach. We need to find what the kids that are, well, young adults that are getting out of school are looking for in their life, and what they're wanting as they progress into our services. So, you know, case management and collaboration are not a new issue with us. We're facing some challenges, as Nan mentioned. I don't necessarily know what the ADRC does. We have the RICOs that are suddenly involved, and then on top of it, in our case, we case manage over 400 people a year, and the feds, CMS is saying that that needs to be divested, and we're currently working with the 5 other like entities on the western slope to maybe form an LLC with Rocky Mountain Health Plans that can take over that, but still maintain that local knowledge and control. So I think, and then access, our main phone number is 945-2306. We have a Watts number that I can't remember what is, but call that number if you know anybody that is needing or is going to be needing services, and we are pretty seamless. And if we can't do it, we have very, very skilled case managers that can find some other entity that can help with that. So, thank you.
Again, my name is Renee Carroll Great, and I'm with Response. I'm very new to the community here, but I'm not new to work in the community. Working in the community has been my lifelong work, lifelong passion. So I'm hoping that I can take my experience and help the community, or Response meet the community's needs. Response provides services for victims of domestic violence as well as sexual assault. We've been doing that work for about 30 years. We primarily serve Pitkin County and some of western Eagle County. We have a mixed population of gender. Probably 95% of our clients that access our services are women. And as it relates to the real world, probably 95% of victims in domestic violence are women. So we're probably seeing a good number of that equation there. As I said, we do have men that we see, which is kind of new and interesting for me. Men started to speak out probably about, or were encouraged to speak out, probably about 10, 15 years ago. So to see that growth, even though it's a small growth, is really encouraging. I worked, prior to coming here, I worked in Texas. So we didn't see a lot of men disclose that issue, probably because of the kind of big, rough, tough cowboy kind of image that Texans tend to carry or adopt. And then after working in Texas, I worked on Cayman Islands. And so that culture also is very different, and probably the male victims did not feel as freely to reach out for help. So saying that, I'm saying that response here in Roaring Fork Valley has really made an impact on a population that I've seen nationally grow really, really slow. Again, like I said, our primary focus is women or adults. We tend to serve people between the ages of 21 to about 55. That's what we're seeing. Most of our clients are of Caucasian origin, although you're real clear that we have a large population of Hispanics in our community that are consequently underserved. And so I think that while we've done a great job, we being Response, in coordinating our work, we've done that a lot with the community. We've worked with law enforcement very closely, worked with Health and Human Services very closely, and other community organizations, and that's probably our strength. And so we celebrate that, and we'll continue to do that collaborative work. But we've got a little weakness there, and that weakness is serving the community, which has been identified as the underserved community. And one of the ways that we're working to hopefully resolve that is through promotoris. I've been practicing saying that word all night, so I hope I said it correctly. Promotoris, I believe is the correct pronunciation. And that word stems from to begin, to promote. The concept is to take the services to the community by using community members. So it's kind of like train the trainer, if you will, but specifically for domestic violence. One way that we do that is the coalition, Colorado Coalition Against Domestic Violence, has a collaborative effort with Response, and now the shelter in Glenwood Springs has joined us. But initially that collaboration was between Response and the state organization, and they secured a grant where the individual would work in our communities, soliciting, recruiting individuals from the communities that we're trying to serve, sharing with them information about the organization, the services that are available, the issue of domestic violence and sexual assault, and how it impacts the community. In return, the community members will reach out and share that information with other individuals in the community. Quite frankly, I see that as plain grassroots work. And for those of you who look like you may have been in the workforce as long as I have, that's not new to us, particularly if you've had the opportunity to live outside of the Roaring Fork Valley. This work, and I'm going to take you back just a little bit because I want you to see that it really isn't much different than what we were trying to do or what we did in the 70s. If you remember, for those of you that are that old and have been in the workforce that long, community organizations were struggling with how to serve the underserved communities, but at that time that wasn't the language. I think we used the term how to become pluralistic, how to, remember that? Diversification, and it's still the same. The population was different though. Who were the groups in the population? African Americans. And I remember that because I was a part of that. And I remember going through that with my colleagues, you know, us learning cultural sensitivity and all that wonderful stuff, and then how to take the message or the need or the services back to the community. Well, one thing I want to share with you that I think I see us repeating, and I want to caution you to not make that error. If you think in terms of leadership, and you know you're always struggling with there's a greater demand than a greater need than there is demand, so you need a lot of stuff, right? But you have very little financial resources. But we're going to try to fix this problem because that's what we do in our work. We're resolutionists, so we're going to fix this problem, and then we find some money. Unfortunately, the money tends to be limited, but nevertheless, we're still going to fix this problem. So we find some money, we hire staff, and typically the staff looks like the culture that we're trying to serve. But guess what, folks? We usually only have one of them, just one. And I can remember, I'm drawing back on my professional experience. I was 21 years old. A part of a group similar to this, looking at pluralism, diversification of services. And they looked at me and said, well, Renee, how do we get to the African American community? Well, that probably wasn't the term they used. Black community, I think is what we were called then or whatever. And I'm like, I don't know. I mean, all I knew was what my family offered. I knew what my world consisted of. But nevertheless, you know, I put my little hat on and I charged forward with, I think there were 3 of us, African Americans, that were charged with diversifying and doing this pluralistic work for a city that had at least 20,000 people, you know? So that's what I see happening here. And so I think we have to put more energy, more resources, and more collaboration. I can't really tell you what Prematuras is the accomplishments they've made because, again, I'm new with the organization. It's just started. Pieces like this take a long time to get off the ground. I can tell you that they use 1 staff member, but the good news is that she's been increased from part-time to now 30 hours a week. That's wonderful. And so what we're looking to do is to share office space with her at Response that'll give us more intimacy with her and then combine our staff member, our resources with some of the work that she's doing. The other piece that we're working on and trying to reach community members is through developing a marketing plan. I honestly believe that past experience shows that you cannot take a flyer and distribute it you know, to the stores or wherever you go and expect people to come. I do believe that if people know about you and they know the benefit that you're serving, they will come. So we're designing a marketing plan for the whole agency, but right now the first piece is for the Hispanic community identified as our underserved community. And I'm looking forward to implementing this marketing plan. And it's nothing rocket scientist. It's a matter of how do we reach them? Where are the community members? Well, they're at work. So we go to our employers, the employers, and talk to them. We've got to go back to grassroots efforts, in my opinion, for response. And that's what I see us doing with this strategic marketing plan. Our collaboration, I'm really, really proud of it. As I mentioned, we do really, really well there. Probably one of the many strengths that Response has. We'll be rolling out a program called AIR, A-I-R, and I don't know what that means, I forgot. But it is with law enforcement in Pitkin County, and we have agreed that every victim of sexual assault and domestic violence who makes a police report will have access to response services. Why is that important? Take a look at the last issue that just came up in the newspaper. You know, and you think about the blame game that's going on. You've read the articles. You know, perhaps, I'm not saying it's a fact, but perhaps if that young lady had the opportunity to receive services the minute she made the police report, perhaps things wouldn't be perceived by the community the way it is. And that's another story, you know, that's talking about the media and disclosures from different agencies, that kind of thing. But our goal is to make sure that each victim who has been traumatized through the act of sexual assault or domestic violence has the availability of resources, not tomorrow, not 3 days later, but immediately. She won't have to look up the phone number. She won't have to call her neighbor and say, what's the name of that agency that I think works with? We will be there for her. And so I see collaborative efforts like this with other community partners getting our message to community members. So I believe that we'll be doing more of the collaborative piece. We've been working, or will be working with Kathleen doing our girls group, support girls group. And if you think about collaboration, for us it made a lot of sense. To start a group on our own, we don't have a captive audience. So we'd have to go out and recruit the girls, which means there's time, resources, financial pieces to that. And Jill, many of you know Jill, came up with the idea of talking with Kathleen, and she has a captive audience. And so our message, our prevention services will be delivered as a service to her girls and our girls. So they become not just her girls, our girls. And that's what they are. There are people in the community. And so I think that we have to, again, go back to grassroots and efforts and figure out a way to do this on a collaborative way so that financially we can make an impact and just use all the resources that we possibly could use. And with that, I'm going to close, but I do want to share one tidbit thing with you. I used to work for the Girl Scouts 30 years ago, and 30 years ago in San Diego, California, the Girl Scouts, I'm really proud of them because they got it right. 30 years ago, they did a national study, and that national study told them that in 30 years, our country's going to look different. It talked about the proportion of brown people to Anglos in the United States. And you know, at first, I think I was 26 or something like that, and I couldn't figure out, why are we doing this? But what happened with that information, if you look at the Girl Scouts handbook, you see brown girls now, you see Anglo girls, you see African American girls, you see people who have physical impairments. And so they took that information and positioned their organization so that they could be prepared to serve the community. Well, the Girl Scouts has a lot of money, so we maybe can or can't do that. But I would just like to say, take a look at the mottos out there that have been successful in doing this work. Thank you.
Hi, I'm Jackie Scramstead. I'm the Regional Director for Mind Springs Health. Today, my focus is going to be, as was announced earlier, we're not talking about the entire continuum of services that we offer, but the real focus is on integrated care, our case management, and peer specialist programs. I wanted to start, though, by reminding everybody that adults without children now qualify for Medicaid. I do continue to hear concerns about access to health care, and I really want to make sure people understand that, because I know for years it was drilled into our heads that single adults were not eligible for Medicaid. People are, and I know, Mary, our rolls are growing in Garfield County. I'm assuming they're growing in Pitkin County as well. But please, just know that. So the folks that are homeless, that are out of work, that are really struggling financially, please make sure we're connecting them with the county, get them set up with Medicaid, not just for mental health services, but for all of their health care needs. I think that's really important. So, integrated care. What is integrated care? For a long time, we've had partnerships, like with Mountain Valley Developmental, where we have a psychiatrist go out and provide services on site for some of our joint clients. We run a group that's co-located at Catholic Charities. They work with us with some space, but that's not really integrated care. That's more co-location. It does bring the services to the people, but integrated care is a whole nother level of integration. We have developed integrated care programs with Mountain Family Health. I'm going to start saying Mountain Valley Developmental now. I'm going to get those confused. Mountain Family Health. We do have integrated care folks on all of those sites, and I'm going to tell you what they're doing. But first, why is that important? If you've been in the field as long as I have, you've known that there is a connection between physical and emotional health, right? We all know that. I think the field is finally starting to recognize that in a more formal kind of a way. And also really recognizing that there's just a lot of complaints that people are going to go to their primary care physician to seek help with. If you have stomach aches, intestinal issues, you're going to go see your doctor. It may not even register that your anxiety or worry may be contributing in some way to that physical issue. If you're having trouble with sleep or energy, people may not clue in, oh, maybe it's depression related. You're going to go see your doctor. I can't sleep. That's where people go. So again, the movement is, how do we get the services to where the people go? The other thing I think that's really important when we talk about integrating all types of health is folks with a mental illness tend to die 25 years earlier than the average other individual. And so when we talk about integrating people's needs, that's really because of challenges with taking care of themselves, accessing health care, following plans when you have some chronic mental illness that may be more difficult. So this integration is really, how do we treat the whole person? How do we bring mental health to where the people go, which is primary care? So one type of individual that we have is called an integrated care clinician. We have 1.5 of these. Well, actually, she's a whole person, but she's there half-time. At Mountain Family Health in Glenwood, we have a half-time position in Eagle and a half-time position in the Basalt Pitkin County Clinic. And what these folks do is not standard therapy. So it's not like you have a little office in the doctor's office and people come and they see you for the 50-minute session and then they leave and therapy as usual. It's very different. So how this works is somebody may come to the doctor and say, I'm having a lot of stomach issues, intestinal issues, and the doctor may do what they do to figure out what that's all about. And they may realize, you know what, this person's really got a high level of anxiety. That's not what I'm going to be able to treat as a primary care physician. So they introduce them to their colleague, Jackie Scramstead, or whoever that is. They introduce them to their colleague, and that integrated care clinician can sit down with that individual and in a more brief intervention help connect with them around some of the other issues that may be connected with the physical complaint that brought them into the doctor's office. It is much more brief intervention. There can be follow-up interventions to that, but the idea is that it is brief, it is more educational, it is providing some behavioral, maybe relaxation in this case, but some different short-term interventions to help folks with issues that may be contributing to their medical complaints. The other thing the integrated care clinician can do through education and even some motivational interviewing is if there is a need for more extensive traditional mental health or substance abuse treatment, they can help bridge that gap and help get the person ready to show up at Mind Springs or some therapist's office. Because you all know with change, you can't just day one say, you know what, I think some of your stomach issues are related to worry. Here's the card to Mind Springs, call them, go set an appointment, they'll help you. That doesn't work, does it? So having somebody in the clinic at Mountain Family that can really help bridge that gap and get people ready to make that step is what integrated care is all about. Let's see. So the other type of integrated care worker that we are also working with Mountain Family Health and Rocky, I should say, Rocky Mountain Health Plans have been partners in these as well. They'd probably want me to mention that. So the community health worker. Community health worker is not a therapist. They are really trained to help with behavior change. And this can be behavior change for any kind of medical issue. Now, I'm guessing I'm not the only person in the room that has ever committed to a behavior change and struggled with that. And what I mean by that is I'm guessing, and you do not have to show your hands, but I'm guessing there's people who have decided tomorrow is the day I'm going to start my new workout plan. Tomorrow is the day I'm going to start this new diet, or I'm going to cut out sugar, or I'm going to give up smoking, right? We can all think of things that we have done, and when we say them, by golly, we mean it, don't we? I am totally going to be walking every day starting tomorrow. It's on my book, I'm doing it, I totally mean that, and then the next day comes and what happens? You start to make excuses, maybe, maybe not, I'll start tomorrow. Behavior change is hard. So what the community health workers are doing is they are getting referrals really from Rocky. Rocky is pulling names of folks that are Rocky Mountain Health Plan customers that are high utilizers of the ER. And the thinking is the reason that these folks are high utilizers of the ER, and they do not have to have a mental health issue, by the way, but is that whatever their medical issue is, or combination of different issues, they are struggling with the behavior change needed to manage their illness in the best possible way. And so they keep coming through the ER. They keep coming to the doctor's office. So what these folks are out there doing is helping walk people, coach people through the behavior change, helping them set up systems, maybe reminding them, making phone calls, driving them to appointments if that would be of help. But really helping bridge that gap from our desire for behavior change and knowing it's important and needed to making it happen. And I think we also know that once you make a behavior change, you can really get into a rhythm with it, right? And then it starts to feel a little more natural. And so these folks are, how do we get, the community health workers are helping people get into a rhythm of taking care of their medical issues. Whether it's dietary, medication, keeping appointments, life skill changes, it's really walking people through that. So these sound awesome, right? Like, why isn't this at every single primary care office all over the Roaring Fork Valley? Wouldn't that be awesome? Healthcare is changing at I swear it's a daily rate. I don't even think I can keep up with the changes in healthcare. But one of the things that's happened is this idea concept is happening. It's implemented. We've had this going on at Mountain Valley for 3 years with integrated care, and it's just gradually expanded. The difficulty is that insurance in the state of Colorado has not kept up with allowing this to be reimbursable. So even though there are codes that we could use, those codes are not open in the state of Colorado. So that's what Sharon Raggio, our CEO, and others in the behavioral health world are really working for some state changes on how do we keep up the policy changes to make this, continue to make this a part of our healthcare continuum. And so that's why you'll see our partnership is with Rocky Mountain Health Plans. They're actually funding this because they believe in the results for the folks that they serve that these types of positions offer. But clearly more change on a policy level is needed for that. The folks who access integrated care, the doorway to that is really through Mountain Family, or if we expand through that primary care. These folks are not coming to our main office to get set up. They're just in their doctor's office and get handed over to somebody and connected in that way. And all of our documentation, when we talk about integrated care, all of that documentation, it lives in the medical chart. They don't have charts with Mind Springs Health. It truly is, we are in that system, part of that system, a team member in that system. Okay, so that's integrated care. Case managers, peer specialists. Case managers have been around forever. Case managers, though, are really seeing an increase right now in the behavioral health world. And part of that, well, a lot of that is related to how fast this area is growing. Healthcare is a growth field. If you've got kids out there, you want to get them into a growth field, healthcare is growing. And I don't know what the current stats are now. I remember when Sharon Raggio addressed our team a year ago when we were doing the crisis stuff expansion. There were like 500 and some open positions in behavioral health agencies like Mind Springs statewide. There are not enough therapists to step in and fill all of those positions. So part of the movement with case managers is to keep some of that coordination of care functioning, getting people connected to resources, a lot of that traditional helping people apply for stuff. But the other thing you're going to be seeing with case managers is an increased level of supportive services and delivering services at their appropriate educational level under the direction of a therapist. And so you're going to be seeing case managers more and more as therapist extenders. So let me tell you a little bit about what that may look like. Let's say we have a client, and for those of you who know me, DBT has been part of my heart and soul for many, many years. So let's say we have a high needs client who struggles with thoughts of suicide on a regular basis, has a lot of challenges. Maybe the therapist sees this person once a week for individual. Maybe they're in our DBT group. And then we decide, you know what, I'd really like to have another contact with this person. But we can't make maybe 2 individual therapy sessions in a week work. So what can we do? The therapist can work with the case manager to say, you know what, I would like for you once a week to do these mindfulness practices with this person. Mindfulness is a lot like being in the present moment, some relaxation. I want you to do this. Or we may have a case manager trained in DBT to be able to do some skill work in between therapy and groups. So that again, we've given somebody a meaningful contact, they're learning the skills, but we're extending the therapist so they're not meeting with the person 2 and 3 times a week, but they're meeting with them weekly, and we have a group with the therapist led. So that may be one way you're seeing things happen. I know we were just talking about another opportunity where somebody is struggling with depression. The therapist has her plan. This person has some risk, and we wanted the case manager to see them in between. And again, giving the case manager a very clear assignment, which was to help this person who doesn't have a real structured day, so they sit around and think about things that upset them, right? So this case manager's plan for their session or 2 that they're going to see this person is to not only check in and see how they're doing, but also to work with this person on a structure for the day. What are some things that they could add to their day? What are some of their interests? how can we help you set up a plan to follow so you're not just sitting in your easy chair being upset all day and depressed. So those are some of the ways that we are expanding our use of case managers, and you will see more case managers. In the Glenwood office, we have 3. We're working on another partnership with Human Services to add a 4th. The Rifle office has 1, and they are looking to hire another. Eagle, Pitkin, both have case managers, and they're looking to continue to expand that. So this is a growing area. It's also an area we are working at. You know, this is a little bit new, so we're working this out as we go. How we use them, how we maximize our use of therapists and use people with other skill sets to help folks as well. Our case managers also, and this is something that they've done for a long time, is provide a lot of supportive services. So many of our folks with a chronic mental illness out in the community, it's hard to travel to our office. So our case managers go out, they do home visits, they check in with folks, see how they're doing with their wellness and recovery plan and managing their mental health issues. And that is something we continue to do with our case managers. And we do have vehicles in a couple of our locations. Pitkin does not right now, but we can help transport people also to appointments, and again, help reduce barriers and make sure people get the care that they need. Okay, the last position is peer specialist. Mind Springs Health has had a very robust peer specialist program in Mesa County for years. It has taken a while to get some traction in the rural areas. However, I think we just about have peer specialists in all 9 of our rural counties now, at least 1. Pitkin has 1, Eagle has 1, Garfield County has a child and family one, and we are rehiring our adult peer position. So they exist. What is a peer specialist? A peer specialist is someone who has lived experience. So this is somebody who maybe has had a mental health issue, a substance use issue, some kind of behavioral health issue themselves. They are now in recovery, stable in their own wellness, and now they are giving back by being in a position of helping others. This is a paid position, although I know one of the questions from Jill was are there volunteer opportunities? And I'd like to think that this may be an area as we grow our peer program where there may be some opportunities for some volunteer options. Our peers do go through evidence-based training. We don't just say, hey, great, you have lived experience, go forth and do good things. They do go through an evidence-based program. I know one of those is called the Georgia Model. There's a couple others that we utilize. And these folks are trained to run groups, provide individual support, do outreach, be engagement specialists. I think it's very different message when somebody who is struggling with depression and suicide is approached by somebody else who's had a similar life experience to say, hey, I've been there, there is hope, than a professional person. I mean, I think that both have their role, but I think there is some real power and benefit to what peers offer. This does not just exist in Mind Springs. This is a nationwide movement around adding peer specialists to the behavioral health world. And we are also using peers to provide some respite. And so what that would look like in the rural area is, let's say our crisis line was called and the crisis worker goes out, assesses this individual. They don't meet hospital criteria, right? But maybe they're distraught and they just need somebody to sit and be with them for a little while. We can call in a peer and say, you know what, Jackie Scramsted's really just distraught. She doesn't meet hospital criteria. It's not that level. She really needs to connect with somebody though. And our peer can come out and sit with them and be there for them for a couple hours. Because really when people are in crisis, making another connection with somebody else is so important. And so that is a really important service, and that's what we're trying to provide with some of these peers as well, is expand that capability. So let me see if I covered all my notes on peers. Yes. So I'm sure there'll be questions at the end, but I want to make sure Jess gets her chance. So that's just some of the programs. And again, I hope you see the movement is really how do we in the behavioral health world continue to move services to where the people are. I mean, there still will always be a place, I'm sure, for people to come to our office, but to make that more seamless and to have less walls and be out and in the community, a part of the community, a part of entities in the community. And we're willing to partner to continue that movement because it's very important. Thank you.
So I'm here today to talk about something new that actually is a coordinated effort between all 3 public health departments, between Garfield, Eagle, and Pitkin counties. It's called the Care Coordination Network. And before I dive into it, I just want to provide a little bit of clarity around what I'm talking about when I talk about care coordination. So I would say probably within the last 5 years throughout the state and the country, there have been this movement towards implementing positions such as community health workers, promotoras, patient navigators, individuals that are out in the community doing a little bit more intense one-on-one, either hand-holding or counseling, or trying to get people to really implement their behavior changes as we've been talking about today. And that model's really been proven effective. So when I talk about care coordination, I'm talking about the spectrum of individuals that are doing the hand-holding. So this could be in the medical setting, someone like a patient navigator. It could be as simple as a resource navigator, a neighborhood navigator, someone that's just directing an individual to the resources in the community. So this whole process with the Care Coordination Network started about a year ago with a grant opportunity through the Colorado Department of Public Health and Environment, CDPHE. And so I wrote this grant to fund positions of community health workers over 3 years throughout the 3 counties, and it was really great, and it didn't get funded, so kind of left us flailing. And one of the big questions after writing the grant application was, how do you make this sustainable? How do you, through a situation such as a public health department, where you see the benefit of a care coordinator, a community health worker that's out in the community, reducing someone's ER visits, improving someone's health, that the public health department isn't seeing any money come out of this. There isn't really a sustainable funding model. So we kind of brought together a planning team around this idea of, yes, we love the idea of care coordination. No, we don't see any way that this is sustainable without grant funding. And we don't want to turn this into a system or a nonprofit where every couple years we have to apply for more grants and more grants, because that gets exhausting. So through this planning process of a lot of individuals that are sitting in the room today, we came up with this network saying that in our Tri-County area, Garfield, Eagle, and Pitkin, we have a lot of individuals that are doing this kind of work, that are in the community, that are trying to make people healthier, that are maybe don't fit your classic definitions of promotora or community health worker or patient navigator, but are really producing a lot of the same outcomes. So we thought it would be in our best interest, after several months of planning, to bring these individuals together. So I'm just trying to make sure I'm capturing all this. So as we all know, we have a very strong network of organizations throughout these 3 counties. We all like to work together, and we try to work together because we know individually we can't serve the wide needs of our population. So we're trying to pull out the individuals that are serving in the capacity of a care coordinator and bring them into one room to collaborate, to do some professional development and learn about resources. This proved to be a little bit more difficult. I mean, as I said, or as Mitzi said, we just had our first meeting last week. So it's very much in the beginning stages of meeting and figuring out what are the needs of this population. And I think the difficult part that we've seen is, us as kind of higher ups in our organization, we're very familiar with meeting, and we meet a lot and we talk about what we want to see done. But I think those individuals that are really the boots on the ground don't get together that much and don't have the opportunity to do that networking or figuring out who their counterparts in other organizations are. So really trying to drill down to those individuals to make this an opportunity that helps them do their job better, but doesn't take away from the great work that they're doing. I think in a lot of the research that's been done on community health workers and patient navigators, the successful efforts are when it's really driven by those individuals that are doing the work, not necessarily the director of the hospital that's saying, oh yeah, I think we'll really save a lot of money by implementing this. I think by tapping into the doers and the shakers, that's going to really prove to be sustainable. So. That's kind of where we're at. I think we're continuing, or the hope is that this would be a quarterly meeting and a quarterly effort, and to start gaining information from these individuals is also a huge aspect to it. That as someone that wants to see more integration among community organizations, we also want to understand what the true needs of the community are, what the boots on the ground really are seeing. Which organizations are being overutilized, which organizations are being underutilized, which new organizations are funding. I think that's always something that as professionals we're struggling to understand and struggling to find out who's new, who's doing what, where's their overlap, how can we better make our services efficient and streamlined to serve people better. So. So we had a lot of really great representation from Rocky Mountain Health Plans and Mountain Family and a lot of your employees. So it's been really great to see the turnout. I think it's just refining the process and getting individuals that really need to be there and getting people to see the value in doing this. So in the future, I think what we're looking towards is how to have measurable outcomes and how to really measure the impact that all of these individuals across organizations are having without dumping a huge database on them or figuring out what that database could look like. I think as a public health professional, I do want data. I want to know that this is working, but sometimes it's just trusting the process and know that this is a proven model. So yeah, working community-wide across organizations is really our goal, and to ensure that our population is getting served and is leading healthier lives. So I don't know, I'm trying to think if yeah, thank you.
I have a lot of questions, so I'm not really sure which one. I guess here's where I'll come from. So Pitkin County is a funder, right? We have the Healthy Community Fund. We fund a lot of agencies in this room. And I just read all the grants this weekend. So, what I'm seeing is that integrated health, care navigation, care management, case management is a theme in almost every agency. So my question is kind of, I guess, twofold. One is there a tipping point where customized care for every individual is too much for us? And then if it isn't a tipping point, how do we consolidate this care so everyone doesn't have to be a care navigator? Is that a fair question? Okay, that's one of the questions.
I know, I'm trying to think of how to respond.
Yes. I think that and we've been dealing with this for a long time, but what we need to be looking at is, one, not confusing people with too much duplication, as you're saying, where everybody has 6 or 7 case managers, and the government is kind of moving in this direction where they're trying to get one care coordinating organization, and it should probably be who the primary or what the primary need of that individual or family is, and then allow those coordinators behind the scenes to talk to each other, which and again, our closest relationship has been with MindSpring over the years, but we both have people that are called case managers, but I think we have somebody takes the lead.
Yeah.
And we heard multiple times about Rocky Mountain Health Plans, and they are taking, in my opinion, a real leadership role in resolving the issue that you asked about. Man, I have been incredibly impressed with their openness. I originally thought, this is the evil empire. They're a health insurance company, and those of us who have to spend huge sums of money to buy health insurance for our employees don't like health insurance companies. But Rocky's quite different, and I think that's the direction we're moving in, is to have a primary coordinating entity. And all of us need to let go of some turf when that happens, and say, hey, somebody else is the best entity to be the lead on this case, and we'll fill a support need.
Yeah, I agree with Bruce on that, and I think that's something that we've been working with Mountain Family on. They have our community health workers. They also have a care coordination team of their own clients, and sometimes those folks overlap, and so we're really talking about, when we have overlapping folks, how do we, amongst the care coordinators, say who is the lead here, who's really the one orchestrating what's happening. And I think that's going to be important, is that we have that one lead. In the healthcare world, they're also looking at, you've probably heard the term medical home. And again, that's the idea that there is a medical entity, a healthcare entity that is your primary, that is helping sort of drive your healthcare. In terms of the other question, Nan, I really don't know how to answer the question about individualized services, and I'm not really sure how to answer that. I think there's always a tipping point. I think part of this movement, though, the way I see it, is if we can get people in sooner to more lower levels of care to meet people's needs before it becomes crisis, whether it's medical or psychiatric, I think that we will be moving towards a healthier population and maybe needing less of those individual services, or at least for a shorter period of time. That's my hope with healthcare reform and where we're headed.
Okay, does Nan keep going, or do we have? Come on up. Nan will come.
I actually have 2 questions. The first one's around, Renee did this a bit, but can you each reflect on your organization's experience with clients of limited English proficiency?
I'm sorry, I guess I didn't hear.
You already did reflect on that some. I'd love to hear you
You're off the hook, Renee.
More,
Thank you. Okay, I heard my
others did not reflect on that.
I would say for what public health is doing in terms of the care coordination network, because we're trying to recognize that spectrum, that some individuals are working on that promotora or neighborhood navigator level, that we've made it an effort that all of our meetings are in Spanish and English, and that we have interpretation services going on at the same time, and the slides are in Spanish. And I think, kind of, as Renee said, a lot of times organizations only hire, one person of the target population, because usually that's all the organization has capacity to do. So really it's our hope that we're bringing these people into the same room to find strength in numbers, and to really be able to relate and grow their experience and grow their relationships through that.
We've had some challenges with the adult population. We had an opportunity a couple of years ago to be one of the sites for a pilot project in the state on a school to work program. And it ended up failing because when a person turns 21, they have to be documented in order to receive Medicaid services. And the schools in the area, most of the kids coming out, and I think it's a real tragedy, at that time weren't documented. They were born elsewhere. And you know, I unfortunately don't even know what happened to them. They fell off, you know, the conveyor. But now what we're finding, and strategically we're working on this, is the immigrant population in the valley has been here long enough that now we're starting to see lots of people who may not be English speaking that are eligible for services and are needing to revise our delivery models for that. We have several bicultural, bilingual people on our staff. With regards back to, you know, we're talking about adults, but with our early childhood population, 40% of the kids we serve are non-English speaking families. And it's put a bit of a strain on resources because, again, there's no funding for that. Our state funding does not pay for interpreters or translators and things, but in order to meet the needs, it's something that has to be done. And I think it's something that our local communities, it's one of the places that we use our local funds to augment services to be able to hire those people, which we couldn't do if we only had state funding. But I see the need really, really expanding, particularly, as I said, in the last couple of years, because now we're suddenly getting kids who were born in the United States, who are adults, who are entitled the same as anybody else to the supports that any of our nonprofit or governmental entities have available. And that's a good thing, finally.
Yeah. Mind Springs, we you know, I can echo a lot of what Bruce said. We certainly serve quite a few folks with limited English proficiency. We work to get all of our written information out in both Spanish and English. We are working on translating our website to be Spanish as well. In terms of direct service, you know, I would hire as many bilingual people as I could find. It's difficult when you're talking about a therapist. You need somebody who not only has English Spanish and English proficiency, but also the that specific education background to be a therapist or a psychiatrist. That said, I know we were just interviewing a Spanish-speaking psychiatrist as potentially could do some services for the company. We do have in Glenwood and Aspen people who answer the phones, who can answer the phones in Spanish. We have Spanish-speaking case managers. And one of those I am training. You gotta raise them from the ground up to be a therapist. So, you know, every opportunity we're really trying to find ways of serving this community as best as we can. And we do use interpreters, and in the Glenwood office, we actually have a full-time interpreter who is available for our other sites. We also have a relief interpreter in Rifle. Both of those folks have done some credentialed classes on healthcare interpreting, because it's also a value of mine and of Mind Springs that we don't just bring in somebody and say, hey, awesome, you speak Spanish, come on in and interpret. It's a real skill to interpret. And so we're really trying to look at making sure that if we have to use interpreting, that we do it at a quality professional level for the people that we serve.
So my other question is just a broad question, since this is a panel on adult support services. If anyone wants to reflect on kind of what they see as the key needs for the adult population in this valley, or the key challenges for the adult population in the valley.
Well, I will say one thing that just pops into my mind, because I'm already working on maybe bringing in some training, as well as it's something Mind Springs is looking at. It's a little beyond the traditional adult, but we are seeing an aging population, and the geriatric needs, the older adult needs, are just growing by leaps and bounds. I know adult protection struggles with this. I was just talking to our county attorney about some of these changes, and And I just think that's an area of how do we address our current older adult population, and how do we start to build infrastructure as our population continues to age, because I just see that as an area we need some more expertise and probably some systematic community thinking about how we address that.
I think that the biggest issue, I agree with Jackie, and I'd mentioned it earlier, the aging population is something that we have to, and again, we deal with a very small subset of the world of human services, but the aging population is posing challenges that we didn't realize in the past. To me, the biggest barrier that our entity faces is we have staff that are committed to bettering the lives of the people that we support, and they want to spend their time doing that. And it's particularly true with case managers. And the bureaucracy has become almost unbearable in the last few years. Medicaid is a nightmare if you're dependent on it, which we're very dependent on it. Our case managers would rather be problem solving with people and other entities, but the only way they get funding is by sitting in front of a computer and entering 15-minute intervals of contacts. And that's nuts, and I think that's, we're talking about healthcare reform. We also need to be talking to the folks in Baltimore about CMS looking at some changes and allowing the resources that are sent to our communities to actually be used for providing services and not filling out forms or entering data in computers, because they've gone so overboard on what they consider to be accountability that for years, case managers were the most happy and consistent employees that we had, and our turnover in the last 5 years since the Medicaid went to the 15-minute intervals has been phenomenal. I mean, people burn out in a year. They don't want to do it. They want to work with people, and I don't know what we as a community can do about that. I've talked to our U.S. representatives and senators, and they're sympathetic, but nothing happens.
Yeah. If I understood the question correctly, I think for responses population, the challenge is where there was a shift in the domestic violence movement and the sexual assault movement for things to be client-centered. Years and years ago, the victim came to the agency and we had a comprehensive program, counseling, group counseling, education. We were fixing her. And quite honestly, what we heard is that they don't need to be fixed. So we took a more client-centered approach. And what happens is that that looks different for everybody, or differently for everybody. There may be, in the people in the underserved community, we're seeing that the services needed are a little more extensive or beyond what we normally would do. But again, part of that problem, excuse me, facilitated or was used as an excuse to facilitate the abuse. So we're seeing for the adult population that it's one person to work with a family can be more time consuming than for other individuals. And how we're addressing that is taking a look at it and studying it. Can't really say that we have a resolution for the problem yet.
I think just from a public health perspective in that area, everyone knows this, it's kind of the lack of providers that accept Medicaid or new Medicaid and specialists in the region. So as we are getting an aging adult population and as that's growing, it's just, we're gonna need more providers here. We're gonna, need to do something to keep people here, and it's kind of a big burden, and I have no solutions. None.
I just had a quick corollary for you, Renee. Earlier in your presentation, you mentioned that you see mostly the populations up to 55. And that made me wonder, what about the women, mostly women, after 55? I'm wondering where they are in the population or...
Right. There definitely are, I would have to say, if given the statistics, there are probably more victims over that age group than what we're seeing. Excuse me. And so I think that's part of our outreach. Part of when we do our marketing, part of our marketing piece is to reach out to the older women. Now, we have seen people in the age group, but not a lot compared to the numbers in the community. So, yeah.
Other questions? Amber, come on. Amy first, then Amber. And then, okay, Amy, then Lindsay. We will proceed. Very good.
Thank you, Bruce, for bringing up Medicaid. I sat on, I can't vote, but I sat on the United Way Committee for Grants and kind of just led them along. And then I also was on the Garfield County Committee, and I don't know if Nan went through this or not, but the comments were almost similar that were coming out. So I guess part of mine is a statement and part of mine is a question for you all. One of the statements coming out was, oh, that's a duplication of services. I heard that over and over and over. I don't know how we get beyond that. So that would be if you want to address that one. The other one is we noticed a difference in the financials because, of course, there's now more Medicaid money. Because of the Affordable Care Act, and people said, oh, look at all the money they have. I go, no. So we kind of went through the whole bottom line thing with Medicaid money that kind of skewed the data slightly. And the third comment that kept coming out is, no, our tax dollars should be covering that. Those groups are within, whether it was education or whatever, they're already getting a ton of money. So those were the things that just kept coming up in both groups that were separate with no overlap. So that's a long question. You can answer or address any piece of that if you would.
So let me just rephrase. So in your reviewing of the grant applications, those were the comments from the review team about the grants?
The two totally separate review teams that really had nothing to do with each other, per se.
Okay. So non-duplication service.
I know, I'm trying to, Amy, that was a really long thing. Is there a way to summarize
services,
this?
For example, and I hope Laura doesn't mind me saying it, it's like, oh, English in action is the same as literacy outreach. I go, no, different population, different geographically. Right. The Medicaid monies, which some of you probably have and some don't, about, wow, look at all that extra money they got from the government. So I figured Bruce would love to answer that one.
I will.
Yeah,
sure.
And then the other one was, no, we're already giving money to that. Our tax dollars go to huge programs there. Which don't cover you as much as other people in the audience, by the way. So, does that make sense?
Okay. All right. Thank you. Do you want to start?
I love Medicaid. The reason, and I think this is across the scale for all of us, no matter what population we serve. I've done a really valid analysis of cost of providing services across the state of Colorado in my field. And the range, okay, first off, Medicaid funding for most of us is the same whether you're in La Junta or you're in Aspen. But it costs a different amount of money to provide the same service. So in the 20 entities like Mountain Valley across the state, the range is of the state average is 85% to 124% of the state average. And that's a weighted average based on the school district cost of living data for each of, in my case, the 4 counties we serve. We're at the 124% range. So the folks at the 85% have essentially 40% more dollars to do the same job. And that's why the local funds are so important. We can't, based on the funding that we get, and our organization gets about $8.5 million of Medicaid funding a year. Mm-hmm. Well, first off, we carry about $300,000 of that as a receivable that we're financing the state of Colorado's operations, because the only time we'll ever see that is if we close down and it comes in 60 days later. But we cannot meet the needs of our population with those funds because they only cover a portion of the actual cost of doing business. And in my world, I've been working, the state's submitting new Medicaid waivers, trying to get geographic modifiers, and having very little luck because, again, in our 20, and I only know about our service delivery system, but again, I think it's going to fit across the board. There are only 3 programs in the state of Colorado that are over 102% of the average. It's us, Steamboat Springs, and Boulder. So politically, Steamboat Springs, us, and Boulder don't have enough votes in the legislature to make something happen. So therefore, the local money, the United Way, particularly the counties, Pitkin County is extremely generous and appreciated, are what help to fill that gap. And we couldn't do it without those things. So, even though some of us look like we have lots of money coming in, we have huge amounts of money going out.
Yeah. And I would echo what Bruce said. It certainly has improved the ability to provide services and increase staffing, but it has not met all of the gaps, and Medicaid doesn't pay for every need in the community. The other thing, from a behavioral health perspective, is there are folks in our communities that is very important that we serve who do not qualify for Medicaid. And there are also folks in our communities who don't qualify for Medicaid because they work and they make too much money and they haven't yet maybe bought into the healthcare plan, or they are underinsured. They have health care, but they can't afford to use it. The deductible's too big. And when we receive community funding, it allows us to help those people as well, because those people aren't covered by Medicaid, and it allows us to be able to have some flexibility in helping some of those working folks who don't have access to health care, or some of the other folks in our community who don't have access to Medicaid.
I guess I can speak to the non-duplication of services, because that's a hot button of mine. But I think with the grant applications in, I don't know if they're saying they're not going to duplicate services or kind of what the situation is there, but I think as a community, I know we get together a lot, but I think in some way trying to have an efficient method of being up to date on who's doing what and for who and in what area is really important, because we do have a lot of overlapping services and people that are working really hard to accomplish some things and not others, and others overlapping, and everyone, I truly believe, is doing it from a great place in their heart, really trying to serve our community, but figuring out whether it's 211 or whatever we're going to do to really start streamlining our efforts and getting a communication system in place so that we are all aware of what's going on and who to access for what services. So,
if I could just speak to duplication, I think it's really important that the panel members or those that are reviewing it take a look at transportation issues, people wanting to remain in their community, the cost to leave their community. And I don't know if those variables were part of the duplication that you mentioned, but for example, we had a client who needed services several nights ago, and all the hotels in Pitkin County were full. So we reached out to a hotel in Glenwood Springs, and the client's response was, "That's really far." So I don't remember the complexities of her case. I don't know if she had her own transportation. But when one looks at having to leave their community to seek services, I think that's a barrier. So that may be part of the duplication you're seeing. I'm not sure if it is, but I do know when we talk in terms of geograph and clients accessing the services, based on where we're located and where they're located, it presents a problem. We're even starting to look at how we can purchase bus vouchers and make those available to people so that they can get where they need to receive the services.
Jackie, I just wanted to follow up. Is the individual who's in the Basalt in the Mountain Family Health Center, do they speak Spanish?
They do not speak Spanish.
So do they work with somebody who can translate, if that is it?
I believe so, yes.
And then would they also see patients who are children if needed?
Yes, they can.
setting?
Yes,
Okay,
in all of our Mountain Family settings, they could see children and families, yes.
My questions are much more specific and broad. And
Oh, good.
My other question for you, Jackie, is when you have somebody, the behavior specialist who's seeing the clients who are chronically going to the ER, how many individuals can that person work with at a given time? Like, what is the capacity there, and how much need is there?
Right. I think their capacity is somewhere around 15 people at a time. I mean, again, I think the idea is we get somebody stable working their program, and then they don't need that community health worker anymore, and they take a new person. I don't think this is meant to be a lifelong journey with folks, but I think 15 to 20 people is what Rocky's looking at with that.
I'm just curious, is that how many does that fill that need, or are there hundreds of people who chronically use the ER? I just don't have a gauge on that.
I think for the very narrow definition that Rocky's put on this position, that's probably okay. Is there a role for more people to be doing that in the healthcare world? I think absolutely, but that gets back to insurance and funding, and right now insurances, there isn't a way to bill that. And by the way, one of our community health workers she's in Garfield, but she will also take some Spanish-speaking Pitkin folks, is Spanish-speaking, just to say that.
Okay, great. And then Jess, I wanted to ask you, who are the care navigators that you guys are working with? I don't need names, I'm just curious what organizations they're with and how you've identified them.
Sure, so we did kind of a very broad reach this time, which worked to our benefit and also not to our benefit in a couple ways. But so we left it broad. We didn't want to say your job title has to be community health worker or patient navigator. We really looked at, we said, if you're working one-on-one with individuals to improve their health outcomes, then this is for you. That being said, we got a couple people that said, but I already go to the Mid-Valley meetings and I go to the pod meetings. This is a total duplication, and I would say then it's not for those people. It's really for the individuals, we had individuals from Valley Settlement, from Advocate Safe House, from Rocky Mountain Health Plans, from Mine Springs, from from the public health agencies, from human services, from going through from Family Visitor, we had Valley View, we had Mid-Valley Family Practice there. So there was quite a broad range. I think in the future, we might look at separating it out for individuals that are working maybe with more on that community resource level, that are doing more referrals to income assistance, or referrals just to community-based resources, versus individuals that are working within a medical setting and might need to know more about Medicare and Medicaid and those I want to say higher level medical intricacies. So we're definitely still in the planning process and refining process to see, does it make sense to separate these two populations out and then maybe bring them together for resource sharing, or kind of what that would look like. So it's still, yeah, I'm open to suggestions.
Hi. Well, I have a concern, and first I want to share something. I work before like a family advocate, and something I always do with the families is trying to run and catch all the service and try to feed this family to the service. It was really hard because some of the families have a lot of the service have a lot of requirements, and something really big is not only the language or the transportation, it's about the legal status. And every time they have a problem, we try to run around and try to find all the resources. But later we have this big no because you're not legal. Because they're not legal, you can have all these huge opportunities to do it something. I have one case was a lady that she has a really bad depression. I try and encourage to go to Mine Springs, but she don't want to do it because she was afraid to do it. She was not legal, her language, and we say, you know, for the language, we think we cover it. Mine Springs is gonna do something, but she was not feeling comfortable because she was not legal. So we find a pastor in one of the church, and the pastor helped. But I think she still need help. She still need meds. You need more, like, to see a doctor, you know. So that's something that I really want to share. Is, I don't know how it works with you guys or with everybody about legal status, but that's something is huge that closed the door for a lot of families.
Well, and I know that that's a real concern for a lot of folks in the Valley. I do want to say really clearly that we do not report people to immigration. We do not share that information at all. People can come to Mine Springs and get services whether they are documented or not. And, you know, part of my hope with having, I would love to get a peer specialist who's Spanish speaking someday to be able to help do some of that engagement. That's one of my dreams up there on the list. But, you know, my hope also is if this person would even go to Mountain Family, go to the primary care doctor, meet with Sarah out there, and maybe again kind of gradually come into our system. How do we get people feeling comfortable? Because we truly are not a threat related to them being deported, but I know that's a real fear. And so, you know, I think we need some help in bridging the fear and the reality is we're going to serve people without consequences who come to our door.
For us at Response, we don't disclose that the person's status. And so right now with that marketing plan, we are looking for input to direct us of the language we should use. For example, right now we're thinking safe and confidential. But again, need some feedback if safe and confidential actually lends itself to their concerns, because that is a concern that we've heard and looking to address it. But again, for now, as always, any person can come regardless of their legal status. But if you have some suggestions, I'd love to hear it as when we get to pulling that piece together, or anybody out there.
Hi. One of the biggest trends in child welfare that we're seeing right now is in regards to trauma-informed practices. And I think we're making some really exciting shifts in the way that we're treating the families that we see within that program. And I wonder, as we're talking about the older adults or the senior population today, how have you seen that coming into the work that you're doing? And or do you have hopes to start implementing some of those trauma-informed practices?
Yes. So Mind Springs does provide trauma-informed care, and I think there's two different things. There's trauma-informed care, which is really the awareness of the prevalence of trauma and making that awareness a part of all the decisions that we make related to space, what the environment looks like, how we interact with one another, all of those decisions. And I actually sit on our trauma-informed care agency-wide team. So that is something that we have certainly embraced on many levels of the agency. But there's also the evidence-based trauma services, and those we also provide quite a bit of. We just sent quite a few staff from Aspen and Garfield County to it's called TREM, T-R-E-M, and don't ask me what it stands for because I don't remember. But it's a group treatment for people with trauma, adults with trauma. I do have staff who are trained in cognitive processing therapy, which is a lot like trauma-focused CBT in the child world. We have people trained in EMDR. So there's quite a few specialized services as well.
Do you have any hopes for child-parent psychotherapy?
Is this a specific model, you mean?
It is, yeah, for primarily used with survivors of domestic violence and their children. So it's like a co-parenting technique.
Possibly. There are a couple. I know Megan and I, and maybe this is the one, it's just not registering for me, have talked about another family-oriented, trauma-informed practice. It's hard. Sometimes we have to make decisions, much like Nan was saying. You'd like to be able to provide every single evidence-based service out there, and sometimes we have to make decisions because each one costs time and money and fidelity. And so I think we have to look at that. So I'm always open to looking at other models. Does our community need this? Would this be an effective use of our training dollars, which are very small? As we were talking about Medicaid, there are some things that, and that being one, that is hard to pull down with your Medicaid dollars. So we're open to anything that would benefit the community, but that one is not actually on like a to-do list right this moment.
With regard to children, our eligibility are extremely broad. And we have a program, it's, I don't know, $300,000 or $400,000 a year in funding that's called Family Support Services. And we have, if a child is in an environment that has caused a failure to thrive, and the situations you're talking about would make them eligible under that, we can actually provide funding to the family with state funds that don't carry a lot of restrictions for, we pay for tons of family counseling for families. And again, you know, our population is a small subset, but when we get to young children, it's pretty broad, and our early intervention case managers can, you know, put people in touch with supports that could help. And you know, in the cases that you're talking about, the supports are very different from our traditional population, but we do fund a lot of specialized services for families. We have paid for more dad counseling over the years than you can imagine, and it's paid off.
Hey, would you like to ask the final one or two questions?
No, everybody asked all my questions.
Okay, anyone else? One final? Going once? Twice? Okay, well, on behalf of the planning team, just want to thank all four of you for an excellent time today.